welcome everybody to our next Team Primary Care webinar. The topic of this webinar, well, I should introduce myself. I'm Ivy Bergeau. I'm one of the co-leads, one of the co-leading IVs of Team Primary Care. And we're really excited about this next topic. It's like hot off the presses, applying the new Canadian Interprofessional Health Collaborative Competency Framework, and so relevant for the work that we're doing across Team Primary Care. Before I introduce our speakers today, I just want everybody to take time, because we're coming to this webinar from coast to coast to coast, and we want to acknowledge that we are gathered across Canada on territory of First Nations, Inuit, and Métis. Some of these lands have been covered by treaties. Some of the lands are not covered by treaties. In some cases, we are on, as is the case for myself in Ottawa, on unceded, unsurrendered territory. We want to extend our respect to all First Nations, Inuit, and Métis peoples for their valuable past, present, and future contributions to this land. And we recognize that a land acknowledgement is only one small part of disrupting Indigenous erasure and dismantling colonial structures, of which health professional education is definitely a part of that. And so we have integrated the principle of not just reconciliation, but as per the last TPC webinar, reconciliation, in order to integrate that into all of the work that we are doing in Team Primary Care. So if you'd like to take some time to introduce yourself in the chat, acknowledge where you're coming from, that would be super. So we'll go to the next slide. I'm super excited to have two amazing presenters today for Team Primary Care. Lynne Sinclair, who's a senior consultant and partnerships and innovations at the Center for Advancing Collaborative Healthcare and Education, CASH, one of our key team members. She's co-leading the Interprofessional CASH project from Team Primary Care, and she's an assistant professor in the Department of Physical Therapy at the Temerty Faculty of Medicine at the University of Toronto, and also a board of director with the Canadian Interprofessional Health Collaborative, which is where we got to know each other a lot more. Very pleased to have joining us Dean Lising, who's a PhD student in health professions education research. So he's the integration lead at CASH and an education investigator at the Institute for Education and Research University Health Network. He is also an assistant professor in the Department of Physical Therapy at the Temerty Faculty of Medicine, University of Toronto. And so with that, I'd like to pass it over to Lynne and Dean. Thank you so much.
Thank you so much, Ivy. What a warm welcome. We're thrilled and honored to be invited to talk to you today and to share a little of framing around what is happening across the country and give you some, we hope, useful tools and resources that you can use as you go deeper into transforming primary care across our wonderful country. So our learning objectives for today, we hope to help you with reviewing the rationale for advancing interprofessional education and collaborative healthcare. We want to, at the end of this 1 hour session, for you to be able to describe the new Canadian Interprofessional Health Collaborative Competency Framework. We'll explain to you about some of the goals for our revision and some of the new language and framing that we're using. And finally, we hope to help you consider opportunities of how you can integrate these key collaborative competencies into your practice, into your projects, into your curriculum. We will acknowledge that many of you have great experience in this field already and are very comfortable with the current framework. So we want to acknowledge that the domains and the importance of the 6 domains remain. It's just some language and some refresh that's happening, and we'll give you more details on that. But just to say that if you're really experienced with the framework, you will still learn a lot today. And those that are new, we hope that it grounds your work moving forward. We are also very comfortable to share all of our slides in a PDF so that you can have all the citations from the session today. So important to start with a definition. When we talk about interprofessional education, what do we mean? Well, the World Health Organization 2010 definition still stands, which is that interprofessional education occurs when two or more professions learn about, from, and with each other. For what purpose? To enable effective collaboration and improve health outcomes. So please remember about, from, and with as key aspects. If you can design, develop any kind of interprofessional interaction where you learn about each other, from each other, and with each other, you are getting closer to interprofessional collaboration and team-based care. So really, IPE is about learners and staff from different health roles learning about, from, and with. And this necessitates questioning of traditional hierarchy structures and unpacking of power relationships between roles in order for real change to occur. So when we move from the definition for interprofessional education now to thinking about the care that we do in our communities, which is collaborative practice and healthcare. Again, the World Health Organization has a lovely definition, and it really takes it much broader to take the term professional out of the definition and to make sure it's very explicit that this covers all health workers in social and healthcare. So it's really emphasizing that this does include the medical receptionist that answers the phone when you're trying to access your primary care practitioner. This does include the administrative staff and the clinical leads from all professions and all roles. And critically, it really talks about that this is across settings. We want to acknowledge that we see primary care working as one part of our really important healthcare system, and thinking about our client's journey across the system is really important to highlight. When we think about team-based care, we're talking about the entire health and social journey. So why is this so important? Why are organizations and funders really looking at this? Well, we know that if we look at the left-hand side of the screen, there's a lot of fabulous workers in our system doing great interactions with our clients. But often, unfortunately, it looks very horizontal or solo practice, where everyone's working in parallel to each other. On the right-hand side of the screen is really what we're talking about. When one person is not enough, when you've got more complexity and multiple workers, what we want to really support and encourage is a shared integrated care plan where everyone is working on one plan in collaboration, and importantly, that the patient and client and caregivers are involved in creating that plan. So we know that this is hard. Quality care and quality communication are difficult. And if we could have already fixed everything, we would have decades ago. But here's some of the reasons why this is challenging and why we need projects like Team Primary Care to support. We know that there's lots of handoffs from worker to worker, from shift to shift, from clinic to clinic, from specialist to generalist. We also know that all of us have been educated differently. We have different communication styles. We have different dynamics, different experiences. Also, in our health and social world, we have so many short form acronyms and jargon that we use. And what a short form means for one worker or one profession might be very different than what that same acronym means to another point of care. And there are lots of examples of that. So that makes quality communication even more challenging. We also need to acknowledge that there is differences of opinion. There are tensions, there are power, hierarchy, and stereotypes. For all of these reasons, having time and space for teams to pay attention to collaboration and how they work together is really, really critical. Dean is now going to speak to some of the evidence that we see in the field. Over to you, Dean.
Thanks, Lynn. And I think the opportunity is that the evidence is still evolving. And one thing we always do is we always frame things around outcomes. And in many cases, we look to some of the things like systematic reviews, things like Cochrane collaboration, things like trying to examine causal effects. Some of the results of these have actually recognized that we actually are missing the process sometimes, and that some of the recommendations are really looking, while acknowledging that there's some really great outcomes that are being produced across a very diverse field, because let's be honest, we're in all sorts of different places and we have all sorts of different teams. So we have all sorts of different contexts. So context really matters. But the opportunity is that we are seeing evolution of things like more exploration from not just quantitative, but qualitative to mixed method evaluation. We're looking at different types of theory, knowing that the theory was one area that is evolving as we recognize how complex the phenomenon is. So things like critical pedagogy, things like social and sociological approaches, opportunity to look across research disciplines, not just within. So we're giving you a sampling here. I really like, this is just a tip of the iceberg, and really today is not about evidence, or else we can have multiple hours on it. What we did want to establish is that there is strong evidence, but looking at context is really important. So our context, of course, is primary care. So there are some great things around things like the Evolving Family Medicine team. You will find lots of primary care research networks. We just wanted to share one example that was fairly recent that came from our Ontario COVID Science Advisory Table. And we thought this was really important because, one, it was really fresh. We all went through this, but COVID produced some interesting rapid changes, but it also, as much as there were storms all across our system, and I often use weather analogies. So it was a very stormy time. I want to acknowledge that. There were a lot of silver linings because people had to respond, teams had to respond, cultures had to respond. So the opportunity to really see these team-based models shine was a really valuable examination through the pandemic, and recognize that we do see team-based models producing superior support for not just COVID, but non-COVID health issues. As you know, you were stretched all across the system, not just providing for COVID, but being taxed, trying to provide for all your other clients. And as Lynn had mentioned around the arrows moving in the left side, if you remember that, she was saying the solo practices. We are seeing the value in for sure a lot of primary care practices, but we are noting that team-based primary care practices were better able to support integration, especially not just across professions, which is really important because a lot of our work is going to be collaboration across professions, roles, people, but also across the health system with community organizations. So I would say around the opportunity for interorganizational collaboration as well. And we did see a greater capacity for community-led initiatives and close relationships with system partners. So as I said, we could go on and on. This is really nice to see this advisory table recognize that. But why is it important to you? Why is it important to your work? Why is it important to your clients, your families, your communities? So just for a minute or two, go ahead, if you feel comfortable, throw something in the chat box. It could be a few words. It could be a thought around why is it important. I'm just going to read off a few and I'm going to keep going. Just want to, it's more for your pause and reflection to think about, like, why are you here and why is it important to you? But would, love to see a few examples if you feel comfortable putting any words in the chat box that might be around why you think it's important to your work. So I'll just watch for that now. I know you have to be brave to enter anything into the chat box. And it could be one word, it could be multiple words, it could be a thought. Just wondering, why is this important to you and your work?
And Lisa and Dale from TPC, I saw a request for closed captioning. If anyone is able to enable that, that may be useful for other members joining today. Thank you.
Thank you for mentioning that. And I'll just mention a few. Terry, thank you for efficiency and effectiveness. I love Melissa's comment about holistic care, which really for our clients, they often feel like, oh, you're just working my arm or just working my leg, or they're feeling pulled in all directions. Anne mentions care that wraps around, and that's actually timely, accessible, things that are really key components of quality improvement, but also person-centered care. You'll see in the next comment. So I'll let you keep going, and please keep reading. There's some wonderful comments here, but I think we all are here with a bit of common ground. that we think it's important. And I'll let Lynne comment on why we think across nationally that this is important.
I love that. Thanks, Dean. Yeah, grounding this in the personal connection and the personal passion for improving and truly transforming our training and our systems in TPC is a really lovely way of framing this. So transitioning now to introduce to you a little bit about the framework. And the Canadian Interprofessional Health Collaborative is a large group of volunteers that are passionate about strengthening the knowledge base, advocacy, education, and practice change for interprofessional collaboration and innovation. So I'm pleased to be a director on board of director on this. Ivy O'Anderson and Ivy Bourgeau are both directors, and we're thrilled to have the chair of the CIHC, Jacinthe Beauchamp, who will be speaking right at the end of our webinar today. So what is the framework for? Well, we originally developed the framework to really help to define what does being an interprofessional collaboration person mean in our system. And we identified 6 domains that anyone in our system would need to enact to be able to focus as a team on the work that they're doing. So our framework is grounded in team level and practice level. It includes all of those participating in care and services. So that includes all persons, all learners, all practitioners and workers. It relies on integrating knowledge, skills, and attitudes with values. It demonstrates that there's interdependence and intersection across all of the domains, and acknowledging that these domains exist in a context that includes many social, political, legal impacts that impact the way that we do our work. And the framework is very explicit that it covers all contexts and settings, of course, primary care being a primary one. So how has the framework been used up to now? Well, it's been used, we're pleased to find, all over the world. It's actually been a lovely guide for educators, for leaders, for practitioners, for providers to help shape pre-licensure health curriculum. We know that it's been used in post-grad as well. We see it helping to inform creation of competency materials and curriculum. It can help guide person-centered practice. It helps to clarify some barriers that exist, helps to define what we mean in this space, used to validate assessment and design surveys and evaluation. And it's helped inform many of the other countries. We were one of the first to create a competency framework, and many other countries, including the United States, have acknowledged reviewing ours and creating theirs. So why refresh now? Well, first of all, I'll show you the current wording. This is from 2010, and we know that many of you have great experience with this model, but you will note that some of this terminology has changed. Some of our learnings have grown, and we wanted to really think about ways that our system has changed and grown over this last 13 years. So why refresh now? Well, first of all, it was time. We have had a lot of accreditation changes in many of our professions. We've seen strategic priorities, including at our board level, and our IHI, the Institute for Health Improvement, has expanded their aims from triple to quadruple to now quintuple. We're also really appropriately actively responding to gaps and disparities in our system and in our country by responding to calls for justice and action, including, as an example, the Truth and Reconciliation Commission reports, as well as in plain sight reports. And finally, why a refresh now is that the health workforce is in a crisis. There's a cultural shift of attention toward teams and workforce wellness, and certainly a call to action for many of us on Team Primary Care. So sharing with you our refresh journey for the competency framework. We started in 2021, and we're currently in phase where we have done a scoping review. We have done surveys, focus groups, and broad consultations. And the integrated findings are listed on the left-hand side of the screen. It shows some of those learnings and some of those shifts and changes since the creation of the 2010 version. So really focusing on the interdependence across competencies, thinking about EDIJ learnings, more focused on relationships across systems and across people, that persons as partners, language is coming out much stronger, conflicting views read community and how we define community. We knew that the conflict domain was a challenge for some to enact it, so we've made important changes there. We strongly saw that the collaborative leadership domain was a very important aspect of this. We heard from many that talking about leadership and shared decision-making was critical in this framework. Psychological safety of teams and virtual collaborations were critical, and to highlight the theoretical and all of the evidence that's transpired in the last 13 years. So we're thrilled to show you on this next slide our 2023 suggested domain names. We presented these a week ago at the Collaborating Across Borders conference, and we highlight that we've removed the term interprofessional that was used in a lot of the domains to acknowledge the inclusive nature of the framework across all participants. And here we have kept the 6 domains just with some new names. So we're going to now go into mini examples for you. We're going to introduce the new language for each of the domains, and we want to give you an application example. Not to say that our example covers everything, we've just chosen one that potentially would resonate for some of you in primary care areas to think about how you can apply the competency in practice. Over to Dean.
That's great. And as we do that, thank you as well for everyone who just was fairly active in the chats. And there's such great comments here. Please keep going. As Lynn says, these are just examples. You likely have examples. You likely have resources and links. So we hope this can be always, it's always so important to live through our community. So we're going to show some examples and some hopefully, speaking of clarification, some clarification. But what was interesting here is, and just to put it out there, I'm actually, I live this a little bit because I'm both an educator and a clinician. So I teach in the IP curriculum at University of Toronto, where we do have students who need to understand roles. And that was a really important bridge from our former competency statement. But I think the value here is, as a clinician, and I'm a physiotherapist and I work in community and hospital, and I still work in community and hospital, the negotiation is really important. It isn't easy, it's complex and it's messy, and it requires the opportunity to work through that and figure it out together, and it changes day to day. So it is understanding, it's also negotiating, not just my role, but the roles of all partners, of many others who hold similar scopes of practice, who hold similar roles, who day to day we might change our roles to help support each other. And I love this part. So it is about knowledge, skills, and expertise, but the values is really important. We're really appreciating and evaluating how we can actually achieve collaborative, relationship-centered care, services, and community goals. So what was really interesting is we've seen this really evolve, and I've seen this for years. And we do this. I facilitate clinical teams in my role, and one of the things we often do is talk about how can we kind of work through what are all the different things we do, who does something, who can do something if they have the ability and the education, but who should do it. Sometimes someone's more accessible. Sometimes someone has taken additional training. Sometimes 3 people are doing the same thing. And for a client, I'm sure we've all been there where a client said, don't you people talk to each other? You're all asking the same thing. You're all saying the same thing, or they're hearing the opposite, really conflicting things. You're saying different things to me. So this is a really valuable resource guide. And actually, we've seen different versions of this. And I can think years back where I started to use the St. Joseph's models of care map. And I actually had a chance to, in COVID, we had a COVID table that looked a lot like this. But the whole idea is to think and just create space. What do I do? And how does that overlap with others? So on the left side, you can see many different things related to primary care health team activities. And through that, you're going to see a lot of check marks. You're going to see a lot of check marks that have a lot of rows. And what it does create opportunities is to clarify and negotiate roles. So it's just one example, but it's a great one from we've seen from Health Quality Ontario. It is linked to quality improvement, which is great because I actually wasn't looking for our collaborative approach there, but I was looking for quality improvement. And I was like, this is great. I'm glad that it captures that. Team communications is also a really important, always has been very important. As we talked about the handover, the transitions, one really valuable thing that the evolution that we've seen in the competency framework is the idea of thinking about relational elements of care, that it's not simply passing on information, that we need to be collaborative, responsive, respectful. Paying attention to content is important. And I think as you read through they have clarifying statements and descriptors, context is really important as well. And one example of this, we live this, right? We live a virtual context, even today, where communication is different. We are having to sort things out differently than we used to. And we've lost some senses. We've lost some, not just peripheral vision, but we've lost some abilities to really make connections face to face when we are doing some virtual meetings. So this is an example of, I'm going to stop share for a second. I'm going to share a video. It's a team meeting about a client who needs to transition from a care setting to another care setting. So I think it is in a hospital to community base, but it could be really anywhere. The valuable thing here is thinking about how they could have improved their communication. And so I encourage you, as you watch this, you can use the chat right away, but we're gonna look to your thoughts on how they could have improved. And I will hopefully share my screen. Hopefully, if you can't hear it or see it, just somebody tell me, but I think you should be fine.
Okay, welcome back everyone. Hope you had a great lunch. Listen, we're running a bit short on time for our team meeting today. So let's move on to our next patient who's on the list, and it looks like it is Mrs. Holmes. So the main issue we need to discuss today for her is that she's requesting her first weekend pass home, which, as we all know, is a very big deal. Dr. McCarthy, her physician, thinks this should be fine, but she's booked actually for another meeting, so she's not with us today. But she does want to know what we think. Okay, our physiotherapist, we can't hear you.
Sorry, I was on mute. Can you hear me now?
Yeah.
Okay, so you know that my main concern is her mobility. She's progressed really well over the last 2 weeks, but really for her to be safe with her walking, she needs to be supervised. Otherwise,
you know, I agree, but we've been focusing on what she would need at home for the weekend, primarily in the shower. Has anyone actually spoken to the family about this? Should I?
Okay, well, hold on. Okay, she does have a very supportive husband that we know about. He does work full time, but he is actually still willing to meet with us, right? And he tells us she's in pain. Okay, well, hold on. Wait, I see that there's a side conversation in the chat box. Something I can't really see. Mrs. Jones being tired, but I can't see what's in that chat box.
Yes, that was me. Has anyone noticed she's really tired in the day? It's really affecting our therapy.
Okay, look, she's going to really need to have somebody with her at all times, particularly on the stairs. I think she fell going to the bathroom or maybe the shower this week. I do still need to go over safe walking and stair climbing. Oh, I'm sorry, everyone. I really need to get to another meeting. Can you please email me and let me know what happens?
She often tells me she's tired. She has a busy schedule, but this is her third fall. I think we need to reevaluate her medication. Tanya's away on vacation this week, and there's another pharmacist covering for her, but she had another video conference call at this time.
Guys, this discussion is going all over the place. I'm taking minutes today for documentation. I don't think I've captured all of the relevant issues.
And listen, okay, we're almost out of time. I'm not sure what to say to the physician. Like, are we all in agreement? Like, is she ready to go home or what?
Sorry, we have another video conference on this account book next. We all have to get off the line. We do have a meeting coming up soon. Can we S-bar this for next time?
So I probably should have given a trigger warning for the acting, I think, or maybe the actors. You might have recognized younger version of the two presenters today. And if you notice, I've been very civil today. I haven't interrupted Lynn at all. It was, as we think about what could have been better and even what did you see, I will mention, yeah, so we actually adapted that video from a Toronto rehabilitation video that was done far before the pandemic, and we actually worked with the University of Michigan to create another version of this that might be an improved version. But I welcome your thoughts, like just in the chat. What do you think could have improved? And I think, yeah, I'm just looking at fresh comments here. So what could have been better with that? Any thoughts? And you can even just comment on what you saw. Sophia said names instead of jobs descriptions. You know, what's interesting is we catch ourselves all the time in our care settings, right? Saying, oh, that stroke client who's coming, or, you know, oh, that social worker. That's a great point. Sarah mentions an agenda. So that's an interesting part of the competencies, that if you look at the competency, the new competency, it talks about importance of process and structure. Sanjeet mentions ground rules, norms would be helpful. And that's a part that we really, as I mentioned, I do a lot of facilitation with teams. This is one thing that we do want to bring to some of the work in team primary care is attention to many of these things, maintaining focus. Ivy saying who's in charge. That's a really great comment. And that's something that is interesting around facilitation, like who is, you know, who's leading the meeting, but who's also accountable as well. Oh, Deanna mentioned a neutral chair to facilitate. So I'll give a little spoiler. In the version 2 that we did with the University of Michigan, we talk about a rotating chair. So that's one opportunity. Lynn, anything else you want to add before I move on to the next?
No, I just love, yeah, thanks, co-facilitator. I love seeing those comments in the chat, and you can really see how the competencies can be used in debriefing simulation videos like this. We'll be explaining a little bit more how you can access some of the videos, and this is some of the work that Cash can help to support as you roll out team primary care.
Great. So, and there are some links, but the actual YouTube link, it is searchable as well. But one other competency I was going to mention before I pass it to Lynn, the team functioning is really important. And team functioning is an umbrella term that captures a lot. That was one of the terms that I actually I struggle not to do too much with, because there's so much of opportunity here. The talk about interdependence is a really important word that I'm glad to see, and partnership. The fact that we are really dealing with complex decision making is really acknowledging, and it's just calling out what we all know. We have complex decision to make with, and you have complex decision to make with many different stakeholders. And the idea that it is really hard time, it is busy, it is stressful. We were just talking about our back-to-back meeting structures. We have to optimize efficiency. We have to optimize effectiveness. We also have to take care of each other. So the example we give here, and it's just one example, we actually had a chance to publish a paper on the opportunity around resiliency. And what we didn't do, which you're seeing a lot of papers in around COVID time, was talk about individual well-being, how you can, you know, just how you can take care of yourself. What we really want to focus on is how we can take care of ourselves as teams and as communities, and the fact that it's not just on the individual, it's on everybody, and how can we support each other. So this was one example of a community event where we worked with the Schwartz Center from the US, but it could have been any, you're basically just creating space for people to share stories of things that are happening and how to unpackage that. And it really wasn't meant for a solution, but the valuable thing too is we did talk about some tools around checking in with each other, checking out with each other, checking up with each other, how are you, and how are things How can we keep checking in on teams? A really powerful story is one that I heard from my physician colleague who was sharing, and people were very vulnerable at this event. It was a panel, and he was a pediatrician. He talked about he had to look at visual pictures and details of a child that just passed away. And as he's doing this and looking at his iPad, he's looking past it, and his children are playing right behind. And it just he just couldn't take it. It was just too much for him. And it just shared. It was the opportunity to just say, you know, sometimes it's okay to not be okay, and we're running on empty. So just another example. And I'll pass it to Lynn. Talk about collaborative leadership.
Thanks, Dean. So Dean has introduced 3 of the competency domains. He discussed role clarification and negotiation. Second, he talked about team communication. Third was team functioning. I'm now going to do mini theory burst on the next 3. So collaborative leadership. And as you noted with that video clip, someone needs to be leading every interaction that we have, and we can rotate, and it can be context specific. The who is leading that. But we want to support teams to value each other's knowledge, skills, and expertise, and acknowledge that everyone brings different strengths and perspectives to the table. We want to have a culture where everyone is supporting each other and are accountable in shared decision-making and responsibilities to reach common team goals, patient goals, and achievable desired health outcomes. So it's a really important domain that we have in our Canadian framework that actually we don't see in a lot of the other international frameworks. But as you note in that last video, it's something that we've seen really important. And in primary care, this is also equally important. So one of the ways that we can talk about collaborative leadership is to think about leadership questions, those that step into the role of facilitator or as a leader, and the art of asking powerful generative questions and potentially using an appreciative approach, where leaders can ask generative questions that it can ignite change. And this change can simply be started by asking the right kind of questions that inspire teams to think about how could we do this better? How could we do this more together? And it can create more creativity and breakthrough thinking. Now, we want to acknowledge primary care is hard. As Dean just outlined, we've just been through a really tough time for our system. We know our system and primary care is in a health workforce crisis. So it's important to acknowledge when you're thinking about choices of how you speak about collaborative leadership or teamwork, that only having an appreciative approach may not always suit. It is important for teams to engage and validate challenges or harms or difficult, hard things that they're working on as well. So this is just one mini example. What I'd love to do, and it's risky, but I'm going to ask you to close your eyes for a moment. Please don't fall asleep. It is around the lunch hour, but I want you just to close your eyes for a moment. And what I'm asking you to do is pay attention to your body. How does your body viscerally respond when I read these type of questions? And I'm going to ask you at the end of the questions to just jot in the chat a word that it comes to how your body responds. So please close your eyes, and here's some questions. What's the problem? What went wrong? Why bother? Who was a part of this? What happened? Please open your eyes. How did your body respond to those types of questions? Sarah, rigid, tense, defensive, negative, racing heart, flushed. I felt tense, bored, provocative, says Ed. A lot of defensiveness. Thanks, Christine. Okay. I'm going to ask you to do exactly the same thing. Please close your eyes and pay attention to your body. How does your body respond when I read these questions? What's the solution? What's working well? What is needed to make this work best? What small change would make the most difference? What is possible? Can you please open your eyes And let us know in the chat, how did those constructive, optimistic, engaged, positive, hopeful, motivated, curious, strengths-based, positivity, calm, inviting? Thank you for engaging in that mini example. On this slide, what we have done is in a 1-minute example, tried to show you the power of questions and practice. If you look at the left-hand side of the screen, those were the questions I first read out. They're very traditional problem-based or execution-based questions that we've all used, we all are modeling in our system. The second set of questions that I read out are more appreciative or learner, change-based questions that focus on the future and focus on what is possible. We hope that gave you a mini example around the power of questions that we as leaders, as curriculum designers, as facilitators in our system can utilize that can bring more attention to how we ask questions and the way that we can create change. And maybe that will inspire you to read a little bit more with some of our citations around how you might consider using this lovely science and art of asking generative questions. So the next of the core competencies was previously defined as conflict that we've chosen to rename team disagreement processing. Now, we know that's a little bit of an interesting switch, but we heard from teams that don't always feel that conflict aligns to them. They feel that it's more tension or differences of opinion. So our suggested new statement is that teams all actively engage to constructively address disagreements that include team tensions around process of working together, relationships with each other, and the tasks that they're meant to be doing. So this is something that we really know can resonate in primary care, and we've chosen to show another little mini video clip to highlight this. What you're going to see in this clip is a primary care practice clinic, and you're going to see a pharmacist and a nurse practitioner interacting. And what we want you to pay attention to is what tensions may not have been addressed in this clip that should have been addressed. We'll play the clip now.
Hey, you're here.
Hi.
How you doing?
Good. How are you?
Not too bad. Wanted to tell you, I saw one of your patients today, Mr. Takuda.
Okay.
He's on all the meds. We did a med review.
Yeah.
I thought maybe what we could do is combine a couple of his meds, do a combination therapy.
Okay.
And I happened to run into Dr. Mitchell, and he was keen on the idea too, so we just went ahead. I just wanted to let you know.
Oh.
Yeah, we went ahead and did it, so.
Okay.
Yeah.
You know that he is my patient, and I'm sharing care with Dr. Patel.
Right, yeah, I was aware of that. And Dr. Mitchell was there, and the patient got,
Okay.
he wanted.
No, it's good. It's one less.
Okay, friends and colleagues, please in the chat, can you comment? What did you see? What did you feel? What was the tension that wasn't maybe directly responded to there? What did you notice in that video, in that simulation? Some awkwardness, some respect, some exclusion, some disregarding, surprise, shock. People are frustrated just watching it. Yes. Dismissive. Some perceived lack of respect for the nurse practitioner role, some power dynamics. Thank you, Terry. Body language people are noticing. Yes, sitting, standing. The NP was not asked for her opinion, as Carla said. The doctor was, or the pharmacist in this case, was standing the whole time. Stance was authoritative. Some of the nonverbal, there wasn't a common goal. Great, let's keep going. Traditional hierarchy of care, yes. Thank you very much. So in that mini clip, you can show an example in primary care how there all are tensions, there are issues, and you can see the interplay between the competencies in this clip. You can see some communication. You also notice nonverbal communication. You can definitely see some role, lack of understanding perhaps, or need for clarification of role. You can definitely see some tension or conflict coming out. So a great example of the interdependency between the domains. So
I'll
our
just add,
last,
can I add
sorry,
one thing, Lynn? Oh, I have to, you missed the one really good comment from Denise, male versus female. And one thing, so that's a gender power balance. And I wanted to say power, that's one thing that we don't, it's not implicit. It is really explicit, and we need to work through that. So that's one opportunity. We paused it because there's actually another part of this too, but we wanted to actually catch in the moment to think about what would I do at this the most tense spot we could pause it. I just wanted to add that.
And that clip does go on, and there is more tensions that come up. We also have different clips that show that exact scenario that's handled differently to address some of the tensions. So just a way of bringing these competencies to light and highlight for you the importance of thinking about how you can teach and learn about this. So the last of the core competency domains is this important one around collaborative relationship-focused care. So you'll see some changed and refreshed language here, which really supports teams to all dynamically engage in collaborative practice, which involves the purposeful relationships among and between providers and persons that are participating in or receiving care. So all partners coordinate and cooperate in shaping a person-driven care service. And we draw on the literature very heavily in this domain. We can look back to the Pew-Fetzer Task Force report in 2000 that really introduced this idea that we have lots of relationships within our system. We have relationships with our clients and patients. We have relationships between providers, clinician to clinician. We have relationships with our community, with our society, with our regions and our patients, populations, what's happening in our context. And we also have relation to self. So thinking about how we can pause and think about how our teams are working together. So we can draw on the literature to really think about all of the relationships and a way to really encourage us to think about this differently. My lovely co-lead from CASH on team primary care is Dr. Stella Ning, who has presented to other aspects of this team grant to think about how we can integrate what we see in the literature around education science into the how. How do we do IPE? How do we do collaboration? So we've tried to introduce in this webinar that teaching competencies in an embedded and integrative fashion, not just in isolation. We want to show those interplays and those interconnectedness, and hopefully this last video helped to highlight that for you. We also know that this will be challenging, that there will be a change in power, in conversation, in structure and hierarchy. So thinking about experiencing and some of that practicing of it is really important. We love using simulation and videos, but there are other lovely ways of using creative approaches to bring this conversation to your teams. And the time for telling sometimes comes after. So it doesn't always have to be when we think about when we work is doing theory bursts first. We can flip curriculum and allow some experiences or bringing in those practice examples to ground when we then talk about what the literature, the evidence shows us. And one more piece of advice to share with you around how we do IPE, that less is more. It isn't always wise to try and attempt to cover all 6 of the competency domains in one session. try and ensure that key learning is inspired by and not ruled by the competencies. So avoid just teaching constructs or competencies in isolation. That integration and that combination of practice approaches is really important. Bringing meaning, making it authentic to primary care based on experiences, and facilitators play a very key role in this to truly enact purposely, inviting multiple perspectives and possibilities to the table. And that will encourage all of our systems to constantly and critically use reflection to apply and to think about dismantling some of the hierarchical power structures that may exist that are no longer serving our communities and our services. We would like to show you this next slide that highlights ways that you can become involved with CASH, ways that we can help support your projects, support your interprofessional and your teamwork. We will be offering some custom development programs, professional development programs. We are available for consultation and coaching throughout all the primary care teams. We are doing with our wonderful colleagues, including Michael Patton and Dina Hamza, that are on the webinar today, developmental and principle focused evaluation. And we have a lead, Tavis Aperman, who's also on the call today. And we also have tools. Dean Lising created an ACT toolkit, and we are enabling these tools, including our interprofessional compass tool, that can help to support teams to be able to think about the competencies and think about the teamwork that they're doing. So this next slide has our QR code and our website where you can get more information about this. This will also be available on Team Primary Care's website. And Stella and I are the leads for this arm of the project, so you can certainly reach out to us if you'd like more information. So I'm just going to pause for a moment and see if there's any immediate questions or feedback that you have around the competencies and some of the application. We are certainly more than happy to point you to lots of resources and tools. And then finally, before we end today, I'll be passing to Jacinthe Beauchamp, who will talk about the Canadian Interprofessional Health Collaborative and some of our next steps. So just opening the floor for any first comments or reflections. Thank you, Isabelle. Merci beaucoup. Is there a reference for the new framework? Yes, we will be sending out a PDF of our new domain statements, as well as our new draft descriptors or subdomains for each of them. We would like to highlight that this is a work in progress. It is dynamic, and we are currently asking for feedback around the language and the terms and the way that we're positioning. So on one of our next slides, we have a link to a Padlet where you can write some of those pieces of feedback as well. Thank you, Melissa. You like the videos. That's wonderful. We are making those all available for you to be considering in your use. And a key part of that is the facilitation or the debriefs. Did I see a hand up? Hello, Isabel.
Hi, you're gonna laugh, but I'm so glad we had this webinar because we're submitting to ethics today. It's the deadline, and we were awaiting this. And so can I reference this workshop just as a primary reference, and then we can update it? Or what do you suggest? Because there's no way we're going back in time. We're moving forward with our projects. And so what do you think? Thank you. It's very timely.
Merci beaucoup, Isabel. Yes, Jacinthe, as chair, I will speak to you, but I think this has been recorded and is going to be available on Team Primary Care, so I see that as a logical citation. Jacinthe?
I agree, totally. Yes.
Thank you so much.
Thank you. I will now pass to Jacinthe, but I would like to just have you reflect for a moment before we go there. Dean, if you don't mind just going to the previous slide. It's just important to enable that, that learning and that personal reflection. We try to draw on why this is personally important to you. And we would like to just highlight and invite you to think about, is there a learning or a takeaway from today that you can share with your team, that you can share with the project? Did you have an aha moment? Was there an aspect of this that you can please share? We want to think about sustainability with this project. We want to think about transforming our country and our systems, and that requires all of us to be champions and to share. So please, inviting you to consider that. Over to Jacinthe.
Thank you, Lynn, and thank you, Dean, for this very exciting overview of the refresh framework and for the excellent examples of applications. That's really great to see. My name is Jacinthe Beauchamp. I'm the chair of CIHC, and as Lynn has mentioned, we're a network of volunteers. You just saw an example of the amazing work our members do. So we just want to remind you that you can become members, and I think there's a slide showing you some of the benefits of the membership with CIHC. So you have connection with other members who share the same interests as you, regionally, nationally, and also internationally. We're affiliated with IP.global. You have access to live and archive speaker series, which we name Collaboration à la carte. We try to organize them monthly. And this is also connected to our evolving community of practice and discussion groups. So we take those opportunities to share ideas, issues we meet in terms of interprofessional education or collaborative practice. You of course have access to important resources, one of them being the framework, co-construction of the field through our committees and working group. And again, the working group of the competency refresh is one example, but we also have a working group on accreditation that does amazing work. And of course, reduce registration fees for some events, such as the conference that just happened, CAB, Nexus Summit that's happening soon. I think it's in August. I can't quite remember. And the Expo Sim organized by Simulation Canada. And if we go to the next slide, I just want to acknowledge the many people who have been working on this competency refresh. Lynn is one of them, but there's many other people, including a patient partner. And we've been seeking and are still seeking input from different groups, different communities, including patient voices, Indigenous partners. And as Lynn has mentioned, there's the Padlet. You will have more time to look at the different domains, and we invite your comments. We can send a PDF document for you, and you can also contact Carrie Krakowski, the chair of the working group, if you have any comments, suggestions. Again, as Lynn mentioned, it's a living document, it's a working document, and it's our document, so we should all comment and help build it. And I think that's it for me.
Thank you so much, Jacinthe. So just finally, again, emphasizing that all of our slides we will put in PDF and share that out with you. And we are also happy to share a PDF of the new domain statements, as well as the subdomain descriptors that we have in draft that may be useful for your projects. And we look forward to your feedback. My understanding from my TPC colleagues is that there will be a survey sent out. I'm just going to look to maybe Ivy Bourgeot to speak to that.
Yes, absolutely. There'll be a survey launched in Zoom, and we're hoping that you'll take some time before you have to leave us today. I know it's not a lot of time, but just to get some evaluation comments, and that would be super. So thank you. Such a masterclass, Lynn and Dean. Thank you again. Thank you for joining Jacinthe. And there are huge benefits from being a CIHC member. And so I'm looking hopefully to Lisa to launch the survey, and hopefully that will be available to you.
Thanks very much. So I'll just give a big thank you for joining us. We know June is a very busy month. We're thrilled and honored that we were asked to speak, to share this exciting work. We hope this is helpful. We hope it's practical in the application. We do want to sustain and transform our systems and change, and we hope this is one step in the journey. And final word to my co-facilitator, Dean Lising.
No, just if before you go, read through the chat. There's such good comments, and this is what I think these competencies and Team Primary Care will do, is just create spaces to have really insightful chats and applicable to hopefully your teams. And I think the Padlet I hope I put the right link. I copied it from the PowerPoint slide, so it's there now.
Great. Thanks, everybody. Have a great day.